Hey everyone, it's Nurse Dani, and today we are talking preterm labor, and we have an expert here with us today. We're so lucky to have her, Dr. Helen Feltovich, and we actually go back a long ways. You work at Utah Valley Hospital, and that's where I'm from too, and I actually worked with you like almost on a daily basis for a couple of years. I adore her. Anyone who has the opportunity to meet her. I don't want people to have the opportunity to meet you because that means they have a high risk pregnancy. But for those of you who do, you will love her. So tell us a little bit about yourself and your background.
So I've been here at Utah Valley Hospital for 10 years and have known Dani the entire time. And before that, I was in my home state of Minnesota for a few years, but that didn't work out very well until I haven't felt like I'm home till I arrived here in Utah, actually. And before that, I was in training. So I've spent the bulk of my career here in Utah, writing Utah County, and have really been loving it because I get to meet people like Nurse Dani.
We really, truly are so lucky to have you. You're heavily involved in research. We're going to get into that in a little bit, but that's why I wanted to have you on today, because you know a lot about preterm labor. And for anyone who's experienced it, it can be so hard, heart-wrenching, have lasting effects. And so it's a really important topic to discuss. First and foremost, let's define preterm labor. What's preterm and what's full term?
So term delivery is defined as 37 to 40 weeks of gestation. So preterm is anything before 37 weeks.
Including 36 weeks and 6 days.
Including 36 weeks and 6 days. Yeah, and technically anything beneath 16 weeks is considered a miscarriage as opposed to a preterm birth, and there's a little wiggle room around that. People argue about whether that should be 16 weeks or 20 weeks, but somewhere between 16 and 20 up to 36 plus 6 is considered preterm birth. And after 40 weeks, which is a person's due date, the estimated due date, after that point, it's considered either post-dates pregnancy, or 42 weeks or beyond is considered post-term pregnancy.
And there's a problem with both. You don't want to go too far, and you don't want to deliver too early.
Exactly. And that's exactly, pregnancy is amazing, actually, when you think about it, because you have all these different tissues that are all actively changing and remodeling to accommodate this brand new life. So you have the mom, you have the fetus, and you have the placenta, which is kind of an organ all by itself. It's got a life all on its own. And then within that, you have the placenta and then the fetal membranes, which is the bag that surrounds the baby and contains the amniotic fluid. And you have the uterus and the uterine muscle, and you have the cervix. And throughout pregnancy, those tissues all have to interact to grow this baby appropriately. And everything has to happen at exactly the right time. The sweet spot, that 37 to 40 weeks or up to 41 weeks. And when things go wrong, when the timing becomes abnormal, either too early or too late, morbidity increases. So when you think about all the things that have to happen for a pregnancy to grow appropriately, and then at exactly the right time, the cervix to open, which involves it getting shorter, softer, and then dilating open, for the uterus to contract so that the baby will come out, and for the membranes to rupture. And of course, the placenta is probably controlling all of this. When you think about all those interactions happening, it's amazing that most of the time things go okay.
It really is. It's such a miracle every time. I remember thinking that every time I witnessed a delivery, and I've seen a lot of them. I thought that every single time. This is such a miracle from conception to birth. Yep. It goes right most of the time. But there are times when it doesn't, like in the case of preterm delivery.
Yep.
So back to the tissues. Do they actually communicate to determine timing of delivery?
Probably. So I'll go out on a limb here and say, yes, absolutely. Nothing else makes sense. But with respect to how these tissues are communicating with each other, there are a bunch of different theories, and they've changed over time. And right now it's unclear about exactly how that's happening. What we do know is that there is something called an extracellular matrix in pregnancy tissues. And this is kind of like the scaffolding or it provides tissue strength. It's sort of what the tissue is laid down on. And in the cervix, that is mostly collagen. And then there are a bunch of other things, other kinds of cell types and proteins and that. But the collagen in the cervix seems to be pretty well aligned and pretty structured early on. We know this primarily from animal models because we can remove the cervix and look at it under a microscope. So what happens over pregnancy is that collagen structure starts getting disaligned and breaking up. And the tissue goes from the extracellular matrix in the cervical tissue goes from being very aligned and organized and strong and intact over pregnancy to breaking down and becoming very homogeneous, very soft, very much shorter and opening.
So what puts a woman at risk for having this happen too soon?
Yeah, that is one of the great mysteries. You would think that for something that is so common, I mean, every single one of us is born, right? Mm-hmm. You would think that we would by now understand a lot more about it than we do. But the truth is that even though there are lots of theories about what initiates labor, either preterm, at term, or too late, and there is lots of research going into this, the truth is that we don't actually know, like, the initiator of labor. It's fascinating. So the kinds of things that put a woman at risk are being pregnant. That's a risk for preterm birth, or abnormal birth timing. Also, and this isn't a joke, being pregnant with your first baby is a higher risk than being pregnant with your second baby because you're kind of an unknown quantity.
Yeah, we don't know your history.
We don't know your history.
So that means that if you've had a history of full-term delivery, you're more likely to go full-term. And if you've had a history of preterm delivery, you're more likely to deliver preterm.
Exactly. And that is exactly the main risk factor.
Okay, just the unknown.
No, I'm sorry. One of the main risk factors, one of the top 2 risk factors for preterm birth are history of preterm birth.
Okay.
Yep. And the other one is a short cervix in the current pregnancy. Remember, I was talking about how the tissues remodel and change? Well, it appears that when the cervix early in pregnancy starts to shorten too quickly, so if by the middle of pregnancy, 20 weeks or so, the cervix is too short, we know that that has an inverse relationship with length of gestation, meaning that the shorter the cervix is in the middle of the pregnancy, the higher the risk for a preterm birth. Those are the 2 primary risk factors. There are many other risk factors that have to do with demographics and maternal characteristics. For instance, being very young, being under 19 is a higher risk for preterm birth. Being over 40 is a higher risk for preterm birth. Certain body mass indices over 35 to 40 provide an increased risk for preterm birth, as does smoking, some maternal medical conditions like high blood pressure, autoimmune diseases. There's an enormous list of things that are associated, but the only 2 that come out as really strong risk factors are history of preterm birth and short cervix in the current pregnancy.
So if I delivered, so let's start here. It's my first pregnancy. I don't know that I'm at risk for it, and I end up delivering at 28 weeks. The second time, what could I expect to help prevent that from happening again, since everyone knows now that I'm at risk?
So typically you would have a consultation with one of the high-risk doctors like me. At Intermountain, there are many maternal fetal medicine doctors across the system. And we just very carefully go through your entire history, and we try to figure out what could be some of the reasons that would lead up to this. And as I just got done saying, we don't understand preterm birth very well. We don't even understand normal labor, let alone abnormal labor. But we do know that some things increase your risk. For instance, some rare uterine shape anomalies can increase your risk, and some of these things can be fixed. right? There are other conditions that, for instance, bringing a woman's medical conditions under good control can decrease risk. For instance, if someone had out of control diabetes at the time they had a preterm birth, bringing her diabetes under good control can improve her situation. But if it's completely spontaneous and unexplained preterm birth, which most preterm births are, more than 2/3 of them are spontaneous and unexplained. Let me say that a different way. Of spontaneous preterm births, let's back up and define kinds of preterm births first. So one kind of preterm birth is called medically indicated, and that's when there's something the matter, something serious going on with the baby or the mom.
Point to bring up, yeah.
Yeah, that
so like
makes,
if I just delivered it, if I had delivered at 28 weeks because I had severe preeclampsia and had to be induced, that's much different than going into labor spontaneously.
Exactly.
Yeah.
So the first one is medically indicated preterm birth. The second one is spontaneous preterm birth. So out of all the spontaneous preterm births, most of them we cannot find an explanation for. They just happened, which also brings up another important point that there's nothing that a mom can look back and say and blame herself over.
Yeah,
that's a really, really important point.
And that's natural to think like, oh, the day before I delivered, I ran for an extra 20 minutes, or I carried those boxes up the stairs, or
I got really mad and stressed.
And I had a lot of patients come in that said, like, my son jumped on my belly this morning, like all of that kind of stuff. You just have to wash it away because that had nothing to do with it.
Nope.
Nothing to do with it. Yeah, I think that's such an important point to bring up. Thank you for saying that.
Yeah.
Because no one should ever live with the guilt of blaming themselves when they couldn't control it.
Absolutely not.
It takes an already hard situation and makes it even worse if someone's blaming themselves.
Exactly. Yeah. And it doesn't help for the future. If there really were things that we could hold women accountable for, for instance, if doctor said, oh, that wasn't your fault, that, you did X, Y, and Z during your pregnancy, we don't want you to blame yourself. And then we let her go out and get pregnant again and do those same things over again, that would be really unethical, right? Yeah. So we look at those things really carefully, but really, truly, most of the time, it just has nothing to do with what a woman is doing or not doing. It's just kind of a bolt of lightning. So back to if you had a completely unexplained spontaneous preterm birth at 28 weeks, ideally you would come and see someone before you even got pregnant. So you could talk about
mitigating risks. Maybe I can, maybe there's some weight reduction, blood pressure control, maybe thyroid issues are a concern, or blood sugars if I'm diabetic. So those kinds of things are modifiable, and you can go into pregnancy being as healthy as possible.
Yep. We call that optimization.
Optimization. Okay.
Yep. So those are good things. Another really important thing to bring out is spacing of pregnancies.
Oh, yeah. Good point.
We know that with preterm births, having another pregnancy within 18 months of the previous delivery really increases the risk of preterm birth. So,
logically, it just makes sense that everything would kind of need time to
go back
to normal before it's stressed again.
Exactly.
Okay.
Back to the remodeling thing, when you think about the massive changes those tissues are undergoing, and all of them have opposite functions, right? So at first the membranes have to stay really strong and their extracellular matrix has to stay intact until exactly the right moment, and then they have to completely break. It's the opposite. The cervix has to stay long and closed and firm until just the right time, and then it has to do completely the opposite function in order for normal pregnancy to happen. It's kind of amazing to think that even 18 months is enough time for everything to go back.
Now that 18 months, is that from delivery to the beginning of a new pregnancy, or from delivery to delivery?
Delivery to the beginning of a new pregnancy.
Okay, so 18 months before conception, ideally.
Yep. Okay. And that's why we talk to women about highly effective contraception.
So that's an important piece, again, of like optimization and mitigating risk.
Exactly.
Okay, so I've waited to get pregnant because I heard today on the live stream that was important. And I'm going to go talk to a specialist about making sure I can reduce my risks. Now I'm pregnant. Is there anything that can be done to watch me more closely or to further reduce the risk?
Two things.
Okay.
So one of them is, remember we talked about how history and length of the cervix in the current pregnancy were the two most important risk factors. So we address history by offering all women who have had a previous preterm birth that's spontaneous and unexplained, we offer them progesterone supplementation. So this is in the form of an injection weekly, starting somewhere between 16 and 20 weeks and continuing up through the 36 week.
So if I'm 8 weeks along and I've heard progesterone's helpful, I don't need to freak out that I can't get into my doctor until 10 weeks and get progesterone on board because you don't start it till a little bit later?
Exactly.
Okay.
Yep, exactly. And this has been shown in good trials to reduce the risk of preterm birth by about 30%. So unfortunately, that's not 80 or 90 or even 50.
But it's worth it for every single person that benefits from it.
Exactly. And since we don't have good ways to figure out who needs one particular intervention versus another kind of intervention, which we can talk about in a little bit because that's the focus of my lab, trying to figure out what's going on so we can conceive of new interventions. There are interventions out there that right now we don't even have any idea what they are, but we will.
Well, because right now we're kind of in the reactive phase of managing it. We're not quite to the point where we can be proactive.
Right.
With the exception of trying progesterone. And what else? You said there was two things.
So the other one is cervical length. Remember we talked about how the length of the cervix is related to timing of delivery. So that's not a perfect measure. Back about 20 years ago, when this relationship between the length of the cervix in the mid-trimester and gestational age at delivery was established, they found that, there's a general correlation, but in fact, most women with a short cervix, and a short cervix is defined as 25 millimeters or less. It has various definitions actually, but like 10% of the 10th percentile of the population and et cetera. But for all practical intents and purposes, now a short cervix is considered 25 millimeters or less.
Between what gestational age? Because at some point it will naturally start to shorten. So when are you monitoring it?
So that is at any gestational age. That's sort of a threshold definition. But the meaning of that number at different gestational ages is what matters. For instance, after 32 weeks, it's kind of meaningless. Even between 28 and 32 weeks, it's relatively meaningless. The data are strongest for the measurement between about 18 and 22 weeks.
So is that about the time when you check cervical length?
That's, conveniently, that's the time that everybody's having their anatomy survey. The 20-week ultrasound. So that is a really good time to evaluate the cervix. And there are different theories about whether everybody's cervix should be evaluated. That's called universal screening versus selected screening, which is just evaluate women who have had a history of preterm birth. It's very tricky because only 2 to 3% of women will have a short cervix in the middle of pregnancy. And so if you think about,
a lot more go on to deliver prematurely than that.
Exactly.
So you can't always find out that they're at risk at that point.
Exactly. Because we don't understand all the risk factors and how to find them. And about half of women who have a short cervix in the mid part of pregnancy will not deliver preterm. Half. And if in the original studies that looked at this, when they took all the women that did deliver preterm and looked back at what their cervix was in the middle of pregnancy, about half of them had normal cervical lengths. But, so it's not awesome yet. That's why there are lots of people researching this problem because, as you said, it's a tragic problem. I never intended to be a researcher, actually, but preterm birth just kept me awake at night because it's a really, really tragic problem. And it's a global problem and it's a community problem. I mean, preterm birth is really everybody's problem. So that's what kind of drove me down that way. But so back to what we would do for you if you'd had a previous 28-week delivery, we'd offer you the intramuscular progesterone shots. And we would also offer you to monitor your cervix about every couple weeks, starting from around 16 weeks through almost 24 weeks. Okay. Because even though a short cervix has a pretty discrete definition, it is most critical during that 16 to up to 24 week period of time, because that's when the interventions that we know about can be directed. For instance, there's something called a cerclage where we can tie the cervix closed with a suture. And women who have a history of preterm birth, even if they're using the progesterone injections, it's not unreasonable to also monitor their cervix and offer them a cerclage if that cervix shortens below 25 millimeters, because there appears to be added benefit in terms of preterm birth risk reduction if a cerclage is added and the progesterone shots are kept up. There's a whole different kind of intervention also that is also progesterone, and people get confused about this because there are different formulations of progesterone. But so the intramuscular progesterone is for women who have a history of preterm birth. And remember, that's one of the two strongest risk factors. Mm-hmm. The other strong risk factor being short cervix in the current pregnancy. And again, even though it's not perfect, it's the best we have. So, if a woman has a short cervix in the current pregnancy and we offer her vaginal progesterone, so these are suppositories that you do nightly instead of the injection once a week, you do suppositories nightly from time of diagnosis of short cervix up through about 24 weeks through 36 weeks of gestation. Or sometimes people don't want to do the shots, and then even if they have a history, and then we can offer them vaginal progesterone instead. So there's some choice in there. But the risk reduction for using vaginal progesterone in a woman with a short cervix is about the same as using the injections in a woman with a history of preterm birth.
Still about 1 in 3.
Yeah.
That's about how effective it is.
Yeah, it's about 1 in 3. And there's no benefit, not to cut you off, but there's a lot of confusion about different formulations of progesterone, and some people feel like, doubling up on
it's not
more
going to
the
make
better.
66% instead of 33.
Exactly.
Okay.
That doesn't happen. And in fact, you probably just overwhelm the body with progesterone and waste most of it anyway. But it's very clear the society recommendations are that you don't double up on progesterone formulations.
Okay, that's helpful to know too. So let's say that my cervix is looking okay. I've been using progesterone, and now I'm 28 weeks, and I'm getting anxious because this is when I delivered last time. Does preterm delivery usually happen around the same gestational age when you have a history of it?
There is no usually when it comes to preterm birth or preterm labor or preterm rupture of membranes or any of that. So when I was a resident, I was taught that typically when someone has a preterm birth in the first pregnancy, if they, how do I say this? There's so much information.
I know.
Like
really
in a half an hour, again, it's like 20 years of knowing things. So the recurrence risk depends on the gestational age at which the previous preterm birth happened. So if you had a preterm birth at 24 weeks or so, that's a much higher risk in a subsequent pregnancy than if your preterm birth was at 36 weeks or even 28 weeks. So when I was a resident, we were taught that if the preterm birth happened at 28 weeks in the first pregnancy, it would probably be 30 weeks in the next pregnancy and 32 weeks. All of that is
There's no good way to predict it, and we just needed a crystal ball.
Wouldn't that be nice?
I know. If you
That's
could
what we
invent
have to work on.
that would solve a lot of problems. So
I'll get right on that.
You have done so much good in the world on this topic, though. What type of research have you been working on? You've been doing a lot, but Tell us a little bit about it.
So remember when I was talking about the structure of those tissues? So in my lab, we develop technology, ultrasound imaging-based technology, to look at the microstructure of tissues and test how strong they are.
Wow.
In a pregnant woman. That's what we've been working on.
So basically, this would be another indicator or marker for risk.
Yeah, a biomarker, an imaging biomarker of risk. And we look at the cervix, we look at the membranes, we look at the lower uterine segment. We have a huge group of really great labs. I'm surrounded by very smart people who I really believe are going to help pave the way to figuring out this problem.
Get some breakthroughs. You were talking before.
There are labs all over the world that are working on this. People care about this problem a lot.
That's really promising. And we talked a little bit earlier about how this relates to cancer, in the sense that we used to treat all cancers the same and just kind of bombard them with chemo and radiation and every therapy under the sun. And now we've learned that there are different ways to target treatment to get better outcomes.
That's called precision medicine. So using imaging biomarkers and then other kinds of biomarkers, maybe from blood, maybe from little pieces of the tumor itself, that kind of thing. In the oncology space, they've gotten really good at figuring out how to use these things together to target a particular cancer, a particular type of cell in a particular person. And as a result, many cancers are now curable. The previously unthinkable has happened. That's where we need to go with preterm birth. Because right now we think of preterm birth as sort of one entity, but it isn't. It's a name for a collection of disorders that have very individual phenotypes and very individual etiologies. And the more precise we are able to get about what are the specific tissues doing in a specific woman at a specific moment of time, and being able to, so my lab works on imaging biomarkers, but we have lots of friends and colleagues that work on other kinds of biomarkers, and it's going to be collaborations such as these that help us be able to do in preterm birth what the oncologists have been able to do, and put these things together and use them to get very precise about a particular woman's pregnancy and figure out exactly what she needs. And I think we'll see that in our lifetime, Dani. Do you know that the preterm birth rate has only been increasing the past few years, despite since 2014, it has steadily increased?
That is
in the entire world.
Heartbreaking, actually. With all we know, we learn what we don't know. But you'd think we'd be farther ahead.
Well, it dropped a little bit for a few years because of education about things, but even now, when we do the best of the best, we do cervical length, we do progesterone, we do everything appropriately. More and more of that's happening in our country and around the world, and the preterm birth rate is creeping up. But I really believe that enough people are invested in this problem now, and our governments understand that this is a critical social problem. And so funds are being directed now more toward it. And I really think we're going to see some solid solutions, some solid cures, just like they didn't believe decades ago that anyone would ever say that about cancers. I think we're going to get there with preterm birth.
That's so exciting, because a lot of people think of cures in relation to diabetes and cancer and those types of things. But this is speaking to the beginning of life and morbidity throughout the life of a child that's born prematurely too.
Yep.
So, what symptoms? I don't think we would do anyone justice if we didn't talk about the symptoms of preterm labor that may be visible to a woman. Like, when should you get checked out and go to the doctor, regardless of knowing that you have a risk?
So, you know what I tell patients? I tell patients that that it's like going to yoga, right? Be aware of your body, understand what is feeling different to you, and don't be afraid to call your doctor.
There's no way to know if what you're experiencing is concerning or not unless you got checked out.
Unless you let somebody take a look. And if that means that, your doctor takes a look a lot, that's what it means. We understand that when we sign up for, pregnant lady doctor.
Yeah.
When we sign up for obstetrics, we know that, we expect it. Nobody gets frustrated about it.
And best case scenario is getting checked out and being sent home with some peace of mind that everything's okay.
Exactly.
And, if you come in and we can see you sooner rather than later, then maybe there's some things we can do to help prolong the pregnancy a little bit.
Or at least calling, because if you call, then the providers that answer the phone can give you some guidance about when it might be time to come in. And I mean, there are certain classic things like bleeding. Obviously, right? Feeling like your water's broken, right? So leaking, feeling especially early in, around 20 weeks or 24 weeks, early labor, even just like back cramping or pelvic pressure, all of these things, in addition to just what we're all taught about regular painful contractions, all of those things can be symptoms of preterm labor. And all of them, warrant a telephone call, at least.
Well, and I remember I have a very vivid memory of this patient that I had once. She said that she had been at home contracting every 3 minutes for hours, wondering if she should go in or not.
Oh, she should have.
And she this went on for a day before she came in. And my heart was broken because
she was so scared to call.
And when she came in, she was 4 centimeters and delivered later that night. Yeah. And so that just I will forever remember that. And I told everyone who came in, after everyone finds out it's okay, they're like, "Oh, I'm so stupid. I should have just stayed home."
No, there's no stupid.
No, I'm so glad you came today. I'm so glad that we were able to check everything out and tell you that everything looks okay. But just because it looks okay now doesn't mean that you might not contract tonight. And if it happens again tonight, you come right back in.
That's
because
exactly
it's never
right.
a wasted trip.
Nope. And that's what we're here for. But importantly about that woman that, went all day and all night contracting, the truth is that we don't have things to stop preterm labor. We don't have them. We have some things that might slow them down and give us a chance to get steroids into the patient, steroid shots to help the baby's lungs, accelerate maturation a little bit faster. But we really can't stop it.
Yeah.
So it's important to know that too, that,
again, it wasn't her fault.
It wasn't her fault. That's exactly where I was going.
Yep. Because it's kind of like the freight train has started out of the station, and we can only slow it down a little bit, but it's still going.
Yep. And the truth is that freight train started weeks, maybe months before any symptoms, maybe even before she got pregnant. We don't know yet.
Right.
Yeah. So
is there anything else that you feel like families should know about this topic?
Yes. I feel like, again, we women are really good at beating ourselves up about things. And I just want to reiterate over and over again, there are very few things. I mean, you could completely take horrible care of yourself and, that kind of a thing that could hurt your pregnancy. But in general, most women are doing a really good job with their pregnancies. And sometimes things just happen that aren't their fault. It breaks my heart when women beat themselves up about preterm birth. And the second thing is, it never hurts to call. Providers, take call. There's always someone here, especially at Intermountain. There are multiple sources for people to call and get their questions answered and make sure that they are feeling okay about things. So never be afraid to call, like your patient that contracted all night. She must have been so scared and suffering, and there's not a need for that. Pick up the phone.
Absolutely not. We're all there to help.
We're all there to help.
Thank you so much. Those are 2 great messages to end on. We appreciate you giving us your time today, and I'm really excited. Let's talk again another 10 years, 20 years, and see how far we've come.
That sounds good. Maybe even 5.
Oh, I hope that would be even better. Okay, maybe even 5. Okay, we'll talk more about it then.
Thanks for your patience with all the science stuff.
Of course, if you guys have questions in the future for me, you know where to find me on Intermountain Moms, Facebook and Instagram. And you can also check out our YouTube channel where we have a video library of over 4,000 videos, a few of them on preterm labor if you want to learn more.
Wow.
Thanks, everyone, and have a great day.